everybody. My name is Mirbat Alasnag, and I'm the digital editor for CCI Journal. And we're here with another cast where I have Professor Gupta from the Army Institute of Cardiothoracic Sciences in Pune, India. Professor Gupta, thank you for joining us today.
Thank you, Mirvat.
We're going to be discussing a very interesting topic, and we actually don't have a lot of data out there on it. And your latest paper that was published in CCI looked at the use of intravascular lithotripsy for patients with calcified nodules. And you also captured optical coherence tomography images of these patients before and after modification and clinical outcomes subsequently for up to a year, if I'm not mistaken.
Yeah,
So
absolutely.
could you walk us through the methodology very quickly before we get into the results and your findings?
So, Mirvat, as we all know that we get a lot of calcified coronary artery disease with the patients coming to us with the advanced age, diabetic patients with renal dysfunction. And studies have shown that around 43 to 48% of heavily calcified vessels, they have calcified nodules. And, eruptive calcified nodules, they have been linked with acute coronary syndrome, and non-eruptive calcified nodules, they are quite common. And these are the actually most difficult subset to modify. So we felt that there was a gap in the literature. So that is how we did this study. We wanted to examine the impact of IVL on non-eruptive calcified nodule. So we identified 21 patients, those who were having angiographically heavily calcified vessels, requiring PCI, and having non-eruptive calcified nodule on OCT. So we identified 54 calcified nodule with OCT, and we did pre-PCI, pre-IVL OCT, then post-IVL OCT, and then post-PCI OCT. Pre-IVL OCT, we identified the minimal lumen area at calcified nodule, the calcium score, and the arc of the calcium, and the number of calcified nodules. And post IVL, we identify whether calcified nodule is getting fracture or not, what is the site of the fracture, what is the MLA gain, what is the increase in MLA from pre-IVL, OCT. And after putting stent, we measured the MSA at calcified nodule beside overall MSA, stent expansion, edge dissection. Beside all these routine things, we also measured two index, that is asymmetric index or eccentricity index. So asymmetric index was defined as 1 minus minimum oblique maximal diameter at minimum stent area OCT frame at calcified nodule. Means if you have got a nodule and there is, after you have placed a stent, you identified a minimum stent area at a cross section, then you divided minimum stent area divided by maximum stent diameter, and 1 minus this. If your studies have shown that if you have got a asymmetric index of less than 0.3, you have got a symmetrical stent expansion, adequate modification. And same kind of index is eccentricity index. That is a simple division between minimum stent area divided by maximum stent, minimum stent diameter divided by maximum stent diameter. Again, it is a marker of symmetrical stent expansion. So, and the primary endpoint in our study was, primary safety endpoint was, freedom from peri-procedural complication, that was perforation, slow flow, or flow limiting dissections after IVL, or MACE during hospitalization or at 30 days. MACE was defined as composite of myocardial infarction, cardiac death, and ischemia-driven TLR, ischemia-driven TLR. So we found, and the primary efficacy endpoint was less than 30% of diameter stenosis, residual diameter stenosis on angiography, and more than 80% OCT stent expansion on OCT.
So when you looked at your results, were there any particular patterns that you noted in terms of calcium thickness, in terms of calcium distribution, etc., that were more predictive of the lesions yielding to lithotripsy and getting the optimal, fractures and getting the optimal lumen gain that we want before we deliver a stent and then deploy it?
So in this study, Meeravat, the pre-IVL minimum lumen area was 3.9 before IVL. That increased to 3.8. When we did a calcium nodule specific study, we found that in out of 54 nodules, we found calcium fracture in 40 nodules. That was 74%. And we found that base of the nodule was the most common site of fracture that was found in 80% of nodules. We divided, let me tell you how we divided base and apex. In a OCT frame where you are getting a maximum height of the calcified nodule, the upper two-third was apex and lower one-third was the base. So we found that the base was the most common site of most common site of the fracture, and it was seen in 74% of the patients. Number one. Number two, after IVL, the MLA increased from 3.9 to 4.9, and after stent placement, the MLA, the minimum stent area was 7.9.
So
This
that
is
is a
at calcium.
substantial increase in lumen gain. And it's very
Yes,
interesting because, in my practice, I always assumed that the areas that would yield or give in first are the junction between the nodule and the rest of the vessel. So you're
that's
saying,
perfect.
yeah.
That's perfect. Miravatullah, I forgot to tell you one thing. In our study, we found that more than 66%, around 66% of patients, the calcified nodules, they were associated with more than 180-degree arc of calcium. So majority of the calcified nodules, as we know by literature, they are seen in heavily calcified vessel. In our study also, majority of the nodules, they were associated with more than 180-degree arc of calcium. And we know IVL effectivity increases more if more is the arc of the calcium. So I think that was the reason. And few of the pathological studies, they have shown that base of the nodule is the weakest link. And in fact, few cases we found that after you have done IVL modification, sometimes nodule come inside. Actually, it causes basal fracture. There is some retro nodule hematoma that in fact first decreases the luminal area, and finally it gives you a good MSS. And in our study, the asymmetric index was 0.14, and eccentricity index was 0.85, suggestive that we got a symmetrical stent expansion in a majority of the patient. I'm not sure that will be linked with the uh, you know with the outcome, but we do expect that if you are getting a symmetrical stent expansion, you will have a laminar flow
I mean, in
dynamics will be good.
theory, that's right. Yes.
Yeah,
And
yeah.
I think your 1 year outcomes are certainly promising. It'd be nice to get a larger series, hopefully down the line, but it's certainly a pilot that shows us that the theory is correct. Then once you achieve that lumen gain, but you also achieve that configuration, that rounded configuration where everything is more symmetrical, hopefully outcomes are better. Now, I wanted to ask you, you enrolled both patients with an eruptive nodules and those with chronic calcified nodules that were non-eruptive. Was there a difference in those patients in terms of, we always think of eruptive nodules as slightly softer because they've already got cracks and they've got hematomas in them. Was there a difference in how much yield and lumen gain achieved in those compared with the more chronic ones? And was there a difference in the outcomes at 6 months and 1 year?
So, Miravat, this study was purely for impact of IVL on non-eruptive calcified nodule. So, we identified non-eruptive calcified on OCT. One thing you can ask me that 70% of the patients who had an acute coronary syndrome, and we are talking about non-eruptive calcified nodule. Yes, we had a maximum number of patients with ACS, but we deliberately studied non-eruptive calcified nodule because, as you rightly said, that we know that eruptive nodules, they are easily modifiable. You can get a circular area, you can modify them easily, but the major the worst subset is non-eruptive calcified nodule. That is why we did this study. And one thing I forgot to tell you, that in our study we compared two subset: those who got fracture, those who never got fracture. We found that even we compared both the subset, there was no difference in the MLA gain, there was no difference in the in the final minimum stent area also. That goes very well with the CAT disrupt 3 trial. That absence of fracture does not mean the failure of IVL. We may not be seeing the fracture, they may be out of plane, or they may be micro fractures. So in this study, we also compared, for patients with fracture and without fracture, but they had the same minimum stent areas.
Yeah, that was interesting, and I'm glad you brought it up. Now, your study focused primarily on intravascular lithotripsy, but do you think other plaque modification tools, rotablation, orbital atherectomy, etc., do you think those would impact nodular disease calcifications similarly in, lesions that are crossable, obviously, because shockwave has to cross?
Yeah. So I you rightly pointed out there are only I have got a strong belief there are only three modalities that can modify calcified nodule. One is rotational arthrectomy, but for that you need to have a favorable wire bias. If you have got a large 4 mm of right coronary artery, large nodule, but your wire bias is not in your favor, you won't get it. Number two, orbital arthrectomy, that seems to be effective, and it has in few cases, but the evidence is only based on few case reports that it seems to be quite an effective tool for modification of calcified nodules. But we don't have data as far as specifically orbital arthrectomy for calcified nodules. But I feel that can be effective, and this is the study that we pilot study in which we have shown that IVLs, it looks like that they will be effective. Definitely, we need a large studies with large number of patients and multi-centric study to document this.
Have you had, stubborn lesions where you felt you need combination therapies? So you'd need two different modalities to get rid of that calcium?
So, Miravat, we in around 14% of patients, we did rotatripsy. They were long, like at my center, we go for a long calcified lesion. We go for rotational arthrectomy plus IVL. You know that, so this was specific for nodules. So we identified nodules. We knew that it's a long segment. You have got so we did this study when we had only 80 pulses per IVL balloon. Now we have got 120 pulses. Yeah. So that was the reason. Yeah, we did in 3 patients. We did a modification with the rotational arthrectomy, followed by sometimes there are patients long segment lesions. You need to do a synergetic effect between with the rotational arthrectomy and IVL balloon.
So these kind of lesions and complex PCIs, I think image guidance is key. Now we know the guidelines have certainly upgraded image use in
Yeah.
complex lesions. And there is a learning curve for all intracoronary imaging, OCT certainly as well. Post modification OCT, what are your criteria to say my modification has been adequate and now I'm ready to bring the stent?
So in calcified vessel, I always do my post modification imaging, be it OCT, be it IVAS. We know that in majority of patients, if I am using IVL, we'll be able to see fractures. Number one, even if you are not seeing fracture, you will get to see a significant luminal gain. If I am seeing rotational arthrectomy, both IVL and OCT, before putting a stent, I always do my post IVL or post rotational arthrectomy imaging to confirm my modification. Yes, we know if you are in this imaging model, if you're seeing the fracture, you are sure that it's done. Otherwise, another marker is that you have got a significant luminal gain. And third thing, if you're not seeing, you can take a balloon, you can inflate it at low pressure to confirm that okay, your vessel compliance has increased or not. These are 3 methods that I use in my practice.
Very clear and honestly very user-friendly actually points that you brought up. Thank you. Do you find any difference in using intravascular ultrasound as opposed to using optical coherence tomography when it comes to calcium, quantifying and qualifying the type of calcified lesion that you have?
So, if you want to identify calcium, the best sensitivity is of intravascular ultrasound. There is no confusion in that. if you want the maximum sensitivity is of ultra IVUS. So let me tell you, angiography has got a maximum sensitivity of only 38% to identify calcium. With IVUS, its sensitivity goes up to 90-95%. With OCT, the advantage is you can see the depth of the calcium. So with IVUS, you cannot document the depth. Whatever you do, you cannot say that it's a thick calcium or thin calcium. There are a lot of speculation. They say if there is a reverberations, it's a thin or thick, but studies have shown it's not correct. So the only advantage of OCT is yet you can see the depth, the depth of the calcium. But the disadvantage with OCT is its depth is the issue. Again, with the IVUS, you can measure the large vessel. With the IVUS, you can see the deep structure. With OCT, you can't see the deep structure, but the Abbott has, corrected this, limitation by giving the ultrasound tube. Now, the software itself, detecting the calcium for the operator. But yes, I
Artificial.
strongly, yeah. So I strongly feel that if you want to learn a new therapy, if you want to see the effect of new device modification in coronaries, OCT is the best answer.
And another question is, we've always considered calcified lesions primarily in patients such as those with end-stage renal disease and very calcified lesions. In your series, did you see that there was a particular trend that it was patients with chronic kidney disease, or are we just seeing more calcification nowadays than we did a decade ago, say?
Yes, you are right. I think in my study cohort, the 33 persons were diabetic. Okay, and around I believe around 10% they were having CKD. But as we are dealing with more and more, old age patients, we have to see the calcium. We need to identify it. We need to know the, modification tool, so that we should not leave the under-expanded stent, because otherwise we'll have a, poor short as well as long-term outcomes.
And as we wrap up here, thank you very much for your time. What do you think? Your series is really wonderful and eye-opening. What do you think we still need to address in a future larger trial that your study hasn't yet confirmed?
So there are, three major limitations of my study. One is the small sample size. Yes, we need to do studies with a large number of patients. We have to focus on non-eruptive nodules and to see the impact of IVL on non-eruptive nodules with a large number of patients at multi-center studies. And the second limitation was the absence of core lab data in my study. But we in our study that all the angiographies and OCTs, they were read and analyzed by two independent intervention cardiologists, those who are having more than 5 years of experience in imaging. And third limitation was again a single center study. So that is why I strongly feel that we need a multi-centric study to before generalizing this data, but seeing the scarcity of data on the non-eruptive calcified nodule, we believe that this particular paper will add a valuable insight into the literature for this difficult subset of calcified nodule.
Well, thank you very much for your time, and to the audience, stick with us. We're going to have a series of a few more interviews, particularly focusing on intracoronary imaging as well. Thank you again.
Thank you, Mirvat. Thank you, Mirvat. Thank you very much. Bye.